Good afternoon and welcome to Psychiatry Grand Rounds. There is no commercial support for today's program. Any financial relationships of the planners and speakers with commercial interests have been mitigated. If you have a question for our presenter, please hold until the Q&A segment at the end of the talk. And if you're attending virtually and have a question, please submit your question into the Q&A section. A link to the event evaluation will be posted in the chat section. It is my pleasure to introduce Dr. Samuel Dotson, our Psychiatry Program Director.
Thank you. Hi, Kristen. Good morning, everybody, or good day. I get the pleasure to introduce Kristen Nagy, who was one of my first teachers in psychiatry. So I was a medical student when I first worked with her. She's been at Carolina's Medical Center, Carolina's healthcare system, and then Atrium Health and Advocates, gone through many different names, but the same organization for quite some time, and is beloved there as a psychiatric pharmacist. She's one of the people that I keep their number basically on speed dial, and having gone through many different universities, she's still the smartest psychiatric pharmacist that I've ever met, and I reach out to her almost every time there's a new medicine that comes across my desk to ask her a question. So I'm very excited to get to hear her talk about her passion today, which is clozapine. Dr. Kristen Nagy earned her doctorate of pharmacy degree from the University of Buffalo. She's board certified in both pharmacotherapy and psychiatric pharmacy. She has worked with Atrium Health in Charlotte, North Carolina for 18 years, with the past 12 years dedicated to psychiatric care as the clinical pharmacy specialist in psych at Behavioral Health Charlotte, which is the largest psych hospital in that region. Dr. Nagy is passionate about psychopharmacology education, and she has taught didactics across multiple psychiatry residency programs, including Gateway Behavioral Health in Savannah, Atrium Health in Charlotte, and the University of Vermont. She also regularly precepts pharmacy residents and students, fostering the next generation of pharmaceutical and psychiatric professionals, and we are very blessed and excited to hear from you today. Thank you very much, Dr. Nagy.
Thank you, Dr. Dodson, for that introduction. It has been a pleasure to watch you grow as well. And I am very, very blessed to be able to speak to you. Just something that's near and dear to my heart is the drug clozapine. So today we're going to kind of talk about it and we'll understand a little bit. I always say you have to understand where you've been to know where we're going. And so that's why it is navigating a really misunderstood medication in my mind. So just FYI, no disclosures. I have been here for so long and I don't do any outside. I just do psychopharm education for different programs on my own time, as I love to speak to anything about psychopharmacology. So today we're going to kind of review some of the histories and the roadblocks of clozapine. I think that's a fascinating piece to understand where it came from. And then what kind of screening things should we be looking for? The unique receptor profile. I find receptors fascinating. It is the bread and butter of what I do and can tell you receptor affinities randomly off the top of my head. And also kind of discuss how we would work with some of the potential adverse effects associated with clozapine. So I have a couple of pre-questions just to kind of see where you're at. If you're online, go ahead and you can answer into the chat. If you're live in person, just kind of think about what you would answer, and we will talk about all these things. So which major event most significantly delayed clozapine's progress towards FDA approval? Was it the discovery of its atypicality as antipsychotic profile, the findings of high heart rate in U.S. trials, the granulocytosis-related deaths in Finland in 1975, or the rejection of the initial 1983 new drug application? So I'll give you a moment to kind of think about that, but we will kind of be covering this in our lecture here today. Second question to kind of think about, which of the following is recommended as baseline screening before starting clozapine? So CRP, ESR and troponin, CBC with diff, with the vitals and an EKG, a BNP and a chest x-ray, or serum concentrations of clozapine. And lastly, which receptor activity is most associated with clozapine-induced hypersalivation? Is it the D2 dopamine antagonism? Is it histamine 1 blockade? Is it norclozapine's muscarinic 4 agonism and alpha 2 antagonism? or clozapine's high affinity for 5-HT2 serotonin receptors. So a little bit of the history. I think it's fascinating. It was actually like the second antipsychotic that was discovered. Chlorpromazine was discovered in 1953, and they went on to continue to develop more and more different antipsychotic medications from there. But in 1958, Wander Pharmaceuticals, a Swiss company, found the molecule of clozapine, but they were like, this isn't an antipsychotic. It doesn't cause neurolepsis. So they kind of put it up onto a shelf and thought, it's defective. Maybe we'll get back to it. In the 1960s, they kind of took it down and started looking at it and going, these patients are getting better from their psychotic symptoms without any extrapyramidal symptoms. This is unique. So then in 1972, it was marketed in Switzerland, Austria, West Germany, and Finland, and the US studies began. But just a couple years into its use in these countries, there were 9 deaths in Finland that were associated with the granulocytosis that occurred from clozapine use. So all of a sudden, everything went to a halt. It was put in the back burner now. The US trials were already underway. So there were open label phase 2 trials in young, healthy male volunteers in the prison. So remember, this is in 1972. This is before protected patient populations, but they were also looking for volunteers. And the providers were surprised at the high heart rates that the patients had, even when they started them at the initial doses of 25 milligrams. And so this really led to us having more standardized dosing regimens when we initiate it. One of the first trials that was out there with an N of 9 was at Rockland State Hospital in New York. And they found, hey, these 9 patients, resolution of some of their schizophrenia symptoms with no extrapyramidal symptoms. That's wonderful. So the double-blind trials began, the first one at Bellevue in New York City, and then a multi-center trial of clozapine and chlorpromazine with the goal of enrolling 300 patients. But due to the fact that 1975, Finland, they had 9 deaths. The deaths were due to secondary infections from the granulocytosis. During all this, Wander Laboratories that discovered this sold off to Sandoz as more drug companies keep buying each other out, right? So in 1976 here, Sandoz said, we're done. Wash our hands of it, moving on. And that if they were going to do it, they would have to require safety checks on all patients receiving clozapine. So what did this mean for the U.S.? The U.S. at that point, out of the 300 patients they wanted enrolled in their double-blind trial, they had only gotten 151. So they only got halfway there. The U.S. did say, hey, if your patients are doing well on clozapine, that you can obtain the medication as a compassionate use medication from the drug company with monitoring. And so this is where that monitoring piece of clozapine kind of came in. So today we have it FDA approved. What kind of went into the pathway next of getting it to FDA approval? It is kind of a unique FDA approval, as it does not seem typical of what we see nowadays. So the FDA, at 1982, Sandoz decided to start reevaluating it. The FDA had 2 requirements for the next new drug application. They said in 1983, you can apply with everything you have, all the information in half-done studies you have, and you are not allowed to have any new studies. At that point, that application was rejected. So the FDA put together an advisory board outside of the FDA approval and said, hey, we want you to continue developing this. We see the benefit, but here's how to do that. And they said, we will see if it works in treatment refractory patients, and does it work better than the standard antipsychotics that are already FDA approved. So what they considered, they called study number 30, led by Dr. John Kane, began at 16 sites across the US with those two goals in mind. Is it better than any antipsychotic out there right now in 1984? So not a lot, mainly first generations, right? And is it working in the treatment refractory patients, the ones who have failed other medications? So as I call it around here, the John Kane trial. Clozapine for the treatment-resistant schizophrenic was the title of the trial. It was a 6-week double-blind trial of clozapine versus chlorpromazine. A lot of times when I'm talking about this with my residents, they're like, why did they pick chlorpromazine? Well, they both were discovered around the same time. Both have very similar structures in general. Both have anticholinergic side effects, so a little easier to blind them between the two with sedation and dry mouth, the anticholinergic side effects. To be included in the 6-week trial, they had to have at least 3 periods of treatment in the preceding 5 years with different neuroleptic agents without significant symptomatic relief. So they wanted to see these patients. And so to make sure they were really treatment refractory or treatment resistant, they gave these patients a 6-week trial with haloperidol and then washed out for 7 days between the two medication in the trial. So everybody in here got a 6-week trial of haloperidol first, 7 days of washout, and then was either randomized to clozapine or chlorpromazine. And what they found really overall, they allowed the providers to be flexible, so real world dose adjust as you may. Maximum doses, when I saw these at first, I was surprised. I was like, whoa, I haven't seen doses that high in years. They allowed to go up to 900 milligrams of clozapine or 1,800 milligrams of chlorpromazine. And they used the brief psychiatric rating scale and clinical global impression scale to assess their efficacy, as well as looking for extrapyramidal symptoms. So the results showed that clozapine showed a greater improvement on both the brief psychiatric rating scale and the CGI and earlier. So this improvement was seen as week 1 versus with chlorpromazine, it took a few weeks. Now, there could be a confounder that the haloperidol washout could maybe cause some differences between the extrapyramidal symptoms, but overall clinical improvement for these patients was seen at week 1. And so overall, the patients who had improvement were 4% in the chlorpromazine benztropine patients and 30% of clozapine patients. So this really gained the steam that clozapine needed here in the US. So the FDA said, okay, we will approve it with a catch. So the FDA had, most drugs that come out on the market have a exclusivity to them. Well, the FDA at this point, we had already started the studies, and the exclusivity for Sandoz on clozapine was coming near to the end. So the FDA granted them a 5-year exclusive contract, but said that the patients had to be monitored. So Sandoz itself contracted with Caremark Home Care and Roche Laboratories to offer a bundle deal to all its patients where they would send the patient a week's supply of clozapine and make sure the labs were reported back to Sandoz, and this was all contained into one bundle. As you can imagine, this had significant impacts on availability and affordability. Plus, you're worried about mail carriers and getting meds delivered on time. So at that point, it became the last resort for a lot of psychiatrists because they were worried that their patients just wouldn't get the medications that they needed because they could not go to the local pharmacies. And by 1997, each generic started arriving to the market, but each had its own registry for ANC and white blood cell monitoring. Well, this caused confusion, and us pharmacists, we like control. So it kind of happened where we were like, Each drug company had a different website that you had to log into. It's not a narrow therapeutic drug. It's not something that has to be maintained on a certain generic or a certain brand name. So this was really confusing to patients if they went to one pharmacy in this town, but in the next pharmacy couldn't receive it because they didn't have the labs at that pharmacy. So at this point, around the time the generics started coming out, Sandoz itself merged with Novartis. And in 1997, like I said, the first generic was approved. At that time, Novartis also said, hey, if your patients have been on clozapine for 6 months and have been within normal limits of white blood cell count and ANC, because both of them were being monitored concurrently at the time, they could move to every 2-week monitoring. So from the early 90s through 97, these patients were getting monitored weekly, continuously, even if they had no breaks in therapy. Then in 2005, I'm almost ready to graduate. They go, hey, you know what? If you've been on it for over a year, now we can move it to monthly monitoring. And I was like, whoa, this is great. Now my patients only have to come in once a month to get labs drawn. But we still had the concern that all these different generics had their own registries and nobody talked to each other. So in 2015, as I was starting my job here, the FDA said, hey, we're going to make it easier. So they consolidated all the registries to one website. Great thought, great concept, poor execution. The site went down for the first 6 months. Nobody could log onto it. When you would call up, the clozapine representatives would say, hey, do what's in the best interest of patient care. And in my mind, that was get my patients had a lab, I could see it. We're giving our patient their medication. So we kind of ended up in COVID. So in COVID times, 2020, we were told all our patients to stay home. Don't come in for your lab monitoring. We will prescribe your clozapine and just keep taking your medications. And so I think the FDA, this is my own personal opinion, might have been a little bored during COVID apparently, and decided to revamp the entire clozapine REMS website again. Now you would have thought, we made such a disaster in 2015. Let's get on board with something that'll work right and work well. Well, what they did is they made all the pharmacies, all the providers, and all the patients re-register. So fill out a bunch of paperwork. And I can tell you from personal experience, I filled out 120 provider forms to re-register and about 20 pharmacy forms to re-register all my pharmacies in the local Charlotte area as one person. And then I had to re-register all our patients into the system after that. What they then said is, hey, we don't need, white blood cell count. We only need the absolute neutrophil count, but we're going to require our pharmacists at the dispensing level to get an RDA, a request for dispense authorization, and our providers have to fill out a form every 37 days saying you are monitoring the patient's ANC. Well, and if those things weren't done, then the patient couldn't refill their meds. So this put one more barrier up for clozapine's use. So you see, when we started in the 70s, after that halt from Finland, we just progressively put up more barriers for our patients, not even socioeconomic barriers or the social determinants of health that we see. These are just added layers for our patients who might not be able to get their medications. Then I was very excited. 2024, a group met with the FDA and brought all the data from during COVID when we didn't monitor our patients and showed them that the risk of having this monitoring program that they implemented in 2021 was causing patients harm. It was a day-long conference, and it was really impactful for myself as somebody who got to watch parents and patients present their case and say how much they loved clozapine and how it's changed their lives. And at that point, the FDA voted 13-1 to officially end the risk the REMS program, which was a risk mitigation program, as it no longer necessarily needed to for the benefits to outweigh, or the risk to outweigh the benefits. And so February 24th, 2025, almost 1 year ago, we have removed our REMS. I don't know about you guys down there, but I want to see this pick up. I want to see our patients on it. And so understanding more about the drug itself will help you hopefully feel more comfortable when you're prescribing it. So now that we know all the barriers to it, now we need to know what the drug actually does. So psychopharmacology of clozapine. Clozapine itself is an active moiety. I love saying the word moiety, and so anytime I can throw that in there, I have to. It's active, but it also has active metabolites such as norclozapine. And what we have found over the years is that clozapine itself binds to some receptors and does one thing, but norclozapine, its active metabolite, binds to some of the same receptors, but does the exact opposite. And so it's really important to understand each receptor and what it's doing and what it should be doing in a theoretical sense. So when we give it to our patients and we see either what we expect or what we don't expect, we understand what receptor it had targeted at that time. So the relevance of our receptor binding. D2, we know it's an antipsychotic, but that's where we see our extrapyramidal symptoms and hyperprolactinemia. And so knowing that D2 is kind of spread throughout the mesolimbic, nigrostriatal, and tubuloinfundibular pathways are really important, that we can't select our antipsychotic yet to say only hit D2 in the mesolimbic pathway. So we have to be prepared for these other pathways. D3 and 4, overall, the clarity of exactly what D4 does is not fully known, but there is some indirect control of glutamate by agonizing or partially agonizing D3. Our serotonin receptors, as we saw, the atypicality of our atypical antipsychotics really come from these serotonin receptors and the amount that they bind to it. They modulate dopamine neurotransmission, trying to mitigate extrapyramidal symptoms, but also can increase appetite and change the satiety of our patients and kind of the cravings of what our patients are eating. Alpha-1, orthostatic hypotension, urinary symptoms. So that is really important when we see this tachycardia and hypotension when we start clozapine. And what's unique about clozapine, it binds to all 5 muscarinic receptors. All 5. Also, its active metabolite will do it, and it does something different. So it's really important to understand that clozapine itself is extremely anticholinergic, and really looking at our other medications that our patients may be on, especially when we're starting this, to start tapering down those other anticholinergics, as well as histamine 1, which is our sedative property. So when we look at where does clozapine itself bind versus norclozapine, the active metabolite, you see there's a lot of overlapping blockade in different areas. Now, norclozapine concentrations will be dependent on 1A2 metabolism, but what we do see is some of our side effects kind of come around from that active metabolite. So understanding that the muscarinic receptors are a big component of that norclozapine receptor binding profile. So looking in vitro, as we know, in vivo, our brain, we have to look in the lab at first and kind of see where it should be binding. And then we put it into our patients and find out it binds in some totally different ways, or it doesn't do what we expect at all. Looking at our D2 affinities, so like golf, we want lower numbers for receptor affinities here. So you see, you have some great 5-HT2A serotonergic binding, 5 and 5 for both clozapine and norclozapine. It is tightly binding there. That is mitigating a lot of the EPS side effects that typical antipsychotics had. What you also see is the muscarinic 1 and 3. You see clozapine itself has tight binding, but norclozapine it has a little less, but it's actually doing something completely opposite at those two receptors. So clozapine is an antagonist at that, so binding it and kind of not allowing acetylcholine to bind there, but norclozapine agonizes at those receptors. And so this is where we see some of the additional side effects, especially as we've titrated the patient up, that they kind of come around. And overall, you see alpha, very tight binding, the low numbers there. This is why the titration has to be individualized for the patient, and especially looking at the antihypertensives or other blood pressure medications that they could be on at that time. So when we compare it to other medications, other antipsychotics we have on the market, so looking at it, clozapine is unique. You see the plus signs, the more plus signs here in my chart, the tighter it's binding. And so chlorpromazine, haloperidol, very well used at the time that clozapine was coming out to the US market. And you see, hey, look, D2 is not as tight. So is really D2 the way of the psychosis hypothesis? It might not be. It has tight serotonin binding. But what it has uniquely, and I find as we continue to move in psychopharmacology, that we are just taking pieces of clozapine's mechanism and piecing them out into different drugs. And so you'll see that clozapine is actually a partial agonist at M4. And it very tightly binds there, as does chlorpromazine, but it's an antagonist there. But that partial agonism will change dopaminergic concentrations. And so that's where we're getting some antipsychotic benefit possibly from clozapine, as it's not binding tightly to D2. And as you look down with some of our now atypical or second generation, and what I consider almost third generation, is aripiprazole. They kind of steer away from that muscarinic, so the sedative component and the other benefits of binding at muscarinic receptors are not available, and they keep harping on that serotonin and dopamine, especially with risperidone and aripiprazole. They're pretty tight binding, just doing a little bit of different antagonizing versus partially agonizing. And so you can see a huge variation with clozapine, and why it is not used as often, because there's a lot of side effects, but also the receptor profile is very unique. What I've started to see in some of the literature is there is some binding at glycine transporters, and there might be an NMDA receptor mechanism piece to clozapine. So when we look at schizophrenia and look at the hypotheses of why schizophrenia occurs in the brain, the dopamine hypotheses that we started with, then moving, to serotonin and the flat affect, then moving to glutamate, we kind of can cover all of this with one drug, clozapine, as our other drugs do not have any of this, and they're just kind of piecing it out. So like I said, clozapine, what we realized early on in the US open label trials is we might need to be looking at this a little closer as we titrate it, and not just starting it out like we would any other antipsychotic agent. So at initiation, baseline vitals, you want to get a temperature, you want to make sure they're afebrile, you want to get their starting weight. As we know, this is going to cause some issues. Their resting heart rate and their blood pressure. We want to know where they are. Are they already hypertensive and tachycardic? That will be a good baseline for us as we start the initiation of clozapine. Some baseline labs, a lot of these things are things I do in general, a CBC with differential, as we do need their ANC, lipids, A1C, and I like a comprehensive metabolic profile, a CMP, just to make sure their kidneys and livers are working properly, or where they fall on the dysfunction scale if need be. And I recommend getting an EKG at baseline so we know where we're starting. I like to know where we are so we know where we go. You'll kind of see that about me in general. I like to know the history so I know where we're going. So thinking about it, I did talk about anticholinergics and how anticholinergic clozapine itself is. Well, when we start titration, we want to look at other medications that our patients might be on, not just psychotropics, but other medications for maybe Parkinson's disease or non-psychiatric agents for urinary retention. And so clozapine itself, 50 to 100 milligrams, depending on smoking status, tobacco smoking especially, has the equivalent anticholinergic potency to 1 milligram of benztropine. That's a lot. And a lot of our patients might be on typical antipsychotics such as haloperidol with benztropine, and then we want to transition them to clozapine. We want to make sure that we're transitioning all of their meds that they were on to the new one, or if we're adding on, maybe take it off the benztropine and leaving the haldol, because now we'll have clozapine to mitigate those EPS side effects. Looking at their hypotensive, their antihypertensives, especially if they have hypertension at baseline, and then any other CNS depressants or respiratory depressants. I've seen some labels say, hey, don't have them on benzodiazepines, but if patients are actively agitated, benzodiazepines in a monitored setting in use with clozapine overall has been okay. You just do not want to, if they have respiratory illnesses or COPD or sleep apnea and having difficulty breathing in general, we wouldn't want to be using benzodiazepines anyways, and that additive effect with clozapine could be an issue. So the metabolism, clozapine comes as a tablet and an orally disintegrating tablet. Now remember, orally disintegrating tablets dissolve on the tongue, but you have to swallow that saliva. There is nothing that it's absorbed in the mouth. It does have to be swallowed into the GI tract for absorption. Overall, it has pretty decent bioavailability at 60%, and food has no impact on its absorption. The half-life does get longer the more you take it, so the longer they're on it, it does last longer, but you do want to watch and dose your patient based on their symptoms and their presentation, and not just their renal or hepatic insufficiencies. Clozapine also goes through 5 cytochrome P450 enzymes. The majority is 1A2, and then 2C19, 3A4, 2C9, and 2D6. 2D6 gets the bad rap because a lot of our psychotics and antidepressants go through 2D6, but the interaction at that end is minimal, as only 6% of clozapine is metabolized via that, whereas the other 4 have very strong and larger quantities of metabolism. So that is where I always look for first. This is why having a pharmacist that you trust and can call easily will help you with these drug-drug interactions. So looking at the inhibitor effects, especially at 1A2, fluvoxamine is one of them. I just was stopped in the hall on my way in here, and my resident was like, hey, can I do fluvoxamine with clozapine? And I go, you can. You just want to monitor your concentrations and monitor your patient for oversedation, as fluvoxamine can increase the levels 5 to 10-fold depending on the patient. So start low and keep an eye on the patient a little more closely. 2D6 inhibitors can increase the level usually when they're at higher doses. And so I kind of watch, making sure we're not at high dose on one and high dose on the other, and we're kind of monitoring for the patient's symptoms and side effects. Currently, the only medication that is contraindicated is one of our new ADHD meds, which is viloxazine, as it is a 3A4 inhibitor. And then what we did find a lot during the COVID-19 pandemic is that the acute inflammatory and infectious process actually reduce and inhibit CYP1A2, almost sometimes up to 90%. I had one patient, I like to tell stories about it. During COVID, she was here, we had her on clozapine, and she developed COVID, as we do have kind of a milieu unit with people coming in and out. We sent her out to the tertiary acute care hospital to get treatment for the COVID, and she was a morbidly obese patient as well, and respiratory status was an issue for her. And I checked a clozapine level when she came in as she was on it, and it was within normal range, 350, 400, I think. And during her COVID-19 stay over at the hospital, I was like, she's just not coming off the vent. Can I check a clozapine level? I'm curious as to what's going on. And we saw the clozapine level tripled. Same dose, was given via tube, no other changes except for the COVID-19. And then I started seeing case reports coming out looking at that viral illness actually inhibited the 1A2. And I thought it was just fascinating that this is why we had to come down on our clozapine to get her off the vent, as she was over-sedated. And then looking at inducer effects, this will chew up the clozapine. So understanding if your patient is going to smoke cigarettes, especially tobacco cigarettes and not vape. Vape does not have the same results. Tobacco smoking, especially here in North Carolina, we're on Tobacco Trail here, our patients sometimes are smoking a pack a day. One of my old mentors we had an inpatient outpatient unit here on campus, and he would let them sneak off to smoke, so he would know. He was like, I'm not gonna punish them. I want to see where their clozapine levels are while they're smoking, so I know how much I need to titrate, because that would be a more identifying of what they're doing in the community versus the hospitalization, and that can happen. So just understanding the variation when they do go back from an inpatient setting, if they do resume cigarette smoking. In 2022, they did suggest that some of the typical clozapine titrations, the 12.5, 25 milligrams a day and titrating up, might be too rapid for some Asian ancestry patients or indigenous people of the Americas. And so to kind of keep an eye on it. Really, I say there's no standard titration. It is individualized. This is personalized medicine without all the tests, and we're just checking vitals. So other factors, looking at, their smoking status, are they obese, the CRP, all that should be taken into account when devising your initiation or titration for clozapine. I get the question a lot about when should we draw clozapine levels and how often should we do it? I remind my residents all the time, treat the patient, not the number, right? If the patient's doing well and they're on a dose of clozapine 200 once a day and symptoms are resolved, let's keep it there and continue on. There's a lot of inter and intra patient variability depending on what time they take their dose, when they do get the levels drawn, especially if they're outpatient versus inpatient, what other medications they may doing, tobacco smoking. And so over the last 30 years, plasma clozapine levels have really been best correlated with efficacy over clozapine plus norclozapine or norclozapine levels itself. So ours reports back as clozapine, norclozapine, and then total. Different labs report it differently, but really when we're looking at that therapeutic level for clozapine, we're looking from 250 to 400 of clozapine itself. The norclozapine is really used to track the cytochrome P450 1A2 activity. And so there are some calculations out there that people can do to see their metabolic clearance and their metabolic ratio, and which is great if you want to find out if your patients are rapid metabolizers versus poor metabolizers. But like I remind everybody, let's treat the patient, not the number. If the number is over 600, their level's over 600, kind of looking at that might be increased risk of seizures, which is my next slide here, that doses over 600 or high serum levels could lead to seizures. So at this point, I might look at utilizing an anti-epileptic if I need to as a prophylactic. It is not first line to do that when you're starting clozapine. If the patient's well, keep the patient well, and let's use an anti-epileptic that doesn't interact. Once you've reduced the dose reductions have been shown to decrease the risk of seizures and the incidence of seizures. These are not during initiation, continuation, discontinuation. Seizures can occur at any time. And so monitoring their levels, monitoring their dose as they get to those higher doses, as new drugs get added, that would be a place where I draw a clozapine level, especially if they're on multiple agents. There's a lot of times when I have a patient who comes in frequently and we restart the clozapine, I will always get their level before they leave because I want to know where their therapeutic is based on perfect standards of them taking it every day, so that when they get to the outpatient and maybe they have some drug-drug interactions because of over-the-counter products they might take, or they didn't tell us about some meds that they were taking home, that I can really recheck that level, or if they start smoking again, and get them back to the level, not the dose that was efficacious for that patient. So thinking about the side effects, not just the seizure threshold, severe neutropenia, this is what started it all. So it was labeled as a granulocytosis in a lot of the literature initially. Now it is severe neutropenia. The package insert by the FDA still has the monitoring of weekly, biweekly, and then monthly, depending on how long you've been on clozapine. What we will see is that there have been some new recommendations that have recently come out that possibly will shift, hopefully, this package insert recommendations. Myocarditis and cardiomyopathy. This was one of a big thing I implemented here at Atrium Health was myocarditis monitoring, especially during titration, that we now found as we were monitoring so significantly the ANC for years and years that we kind of forgot about the other stuff, and that myocarditis was actually more of a risk factor and a side effect where we've had to stop clozapine over the last 20 years than the granulocytosis. So based on the 2011 evidence-based myocarditis monitoring protocol by Ronaldson and colleagues in Australia, I based a clozapine monitoring policy here in Charlotte, where we do CRP and troponin weekly with their labs for the first 6 weeks of treatment, and get an EKG at baseline. We don't have access to echoes here very easily, so EKG was a great thing to kind of put in there. We have caught, since I've implemented this, about 4 or 5 patients start trending up on their troponins and CRP, and we've either held the dose and had them evaluated, or we've had to stop where they have developed myocarditis. So it does work. They looked at a lot of other literature. We looked at a lot of other literature and looked at non-specific monitors, but none of them had great predictive value. Really utilizing the troponin with the CRP was the best value that we got looking for a risk of myocarditis. Other common cardiovascular events that occur and are normal during titration is the tachycardia and the orthostatic hypotension. So I try to take our patients off of some of their other alpha blockers that they might be on because they are additive here. And we have with the tachycardia using metoprolol now more and more, as that is our preferred product. But I like to use something that is not lipophilic, that's going to stay central on the and just focus on the heart rate, instead of using something like a propranolol, which is lipophilic and could cross the blood-brain barrier, adding to sedation. And then with the orthostasis, we do have our inpatients be monitored their orthostatic vital signs before each dose of clozapine. And if the patient is symptomatic, so they have symptoms of dizziness, lightheadedness, and have vital signs that are above either 20 milligrams of mercury systolic difference, 10 diastolic, or 10 heart rate, and symptomatic, we definitely will hold a dose. If they are not complaining of it and they just have the vital sign markers, we will usually continue the same dose that they had the night before to kind of get that down regulation of alpha blockade, as tolerance will develop to it. GI hypomotility, and now, the slow GI transit time due to all the anticholinergic side effects. You want to make sure that these patients are on medications for constipation. So starting out, usually in the first week, I'm starting them out on Miralax with their clozapine to make sure, as an osmotic agent, it's pulling water into the small intestines for movement. And it also has the highest quality of evidence out there with clozapine-induced constipation. You want to avoid the psyllium. So that was one of the things here that I saw patients always getting added psyllium, and I'm like, stop, as that is a bulk-forming laxative and will cause a risk of ileus. The soluria or hypersalivation, like I said, it's due to alpha-2 receptor blockade, but it's also due to muscarinic 4 agonism by norclozapine. And so the treatment options over my career have changed from oral, like by mouth, swallowing a tablet anticholinergics, to actual, let's use topical or localized medications to try to treat it first, so we don't be additive to the cholinergic burden that the patient is exposed to. Why soluria and treatment of soluria is so important is the excess salivation can actually lead to pneumonia. And pneumonia is probably the most significant side effect now that we're seeing with clozapine, and especially with the COVID-19 pandemic and patients getting sick then, that was a big deal. It was that hypersalivation and aspirating the saliva. So treatment options are atropine eye drops under the tongue or ipratropium nasal spray in the mouth. They don't taste great. I'll tell you that. They don't taste great, but it does localize the anticholinergic effect that you need for hypersalivation. If need be, you can try clonidine, but you watch for any kind of other orthostasis. One of the ones we used to use a lot, glycopyrrolate, but we saw an increased risk of ileus with this. So definitely it is more my last line now. I have had a few patients get Botox around their salivary glands, and it has worked well. It is hard to get insurance approval for that, though. Metabolic concerns, and I do have some metabolic concerns. I love the fact that just last year, the antipsychotic weight gain guidelines were published and recommended that all patients on clozapine and being started on clozapine get metformin. Metformin is a mild GLP-1 agonist, so this is great. If they can tolerate it, it also kind of moves their GI tract. So diarrhea is usually the side effect of metformin, and clozapine causes constipation. Look there. We can try to mitigate 2 side effects with 1 medication. Different receptors, which is why it's so important to me, is those serotonergic receptors actually are involved in feeding and satiety. And this is why with the potency of clozapine at these serotonergic receptors, we do see increased insulin resistance. We do see changes in their food intake and what they're craving. And so that is one mechanism that their body weight does increase while on clozapine. Another piece to it, metabolic, we don't always think about is the D2 antagonism. That D2 will actually, when it activates, it inhibits food intake. So if we're blocking D2 a lot with our antipsychotics, it's probably increasing appetite and weight gain. Histamine and muscarinic, what we kind of see is these are sedative type receptors and cause sedation for our patients. So they do decrease the body energy physically, and they can also play a role in leptin interaction with H1 receptors. Insulin resistance. So muscarinic 3, there is those receptors on the pancreas itself directly. And so when you look at the two highest likelihood of causing metabolic side effects, olanzapine and clozapine, they both have muscarinic 3 blockade. So could be one of the big mechanisms. Alpha blockade definitely can change, but we don't have direct causation there yet. And then the cannabinoid receptor. We know the CB1 receptor when our patients smoke marijuana or THC products, it stimulates appetite and feeding. And so possibly with some regulation within serotonin and the CB1 receptor, there's interplay that could be increasing weight gain and insulin resistance. So what's going on in this post-REMS era now? We're 1 year into it. The Delphi consensus came out just last year with a panel of 90 members, including pharmacists and psychiatrists, looking at building new ANC guidelines and also algorithms for monitoring the adverse effects, more significant adverse effects now that we see with clozapine, and with the goal to reduce treatment barriers. And so their consensus came out with, hey, severe neutropenia is most likely in the first 6 months. So let's monitor the weekly ANC for 18 weeks. And then after that, move monthly for the first 2 years until you've been on it for 2 years. So 1.5 years now. And then after that, monitor as your provider recommends yearly. If there are some differences or changes in your health structure, getting the ANC and CBC with diff more often, appropriate. But we do not need to be monitoring this weekly, bi-weekly, and monthly, and causing more significant stresses to our patients to get their medication. Also, with the adverse drug event monitoring, they wanted you to look at, this is the most important thing, is looking for constipation, looking for metabolic syndrome, and not focusing so much on the ANC. So getting weight gain, making sure we're testing our patients for any kind of hypotension. So doing our vital signs when they come in. Also looking at their medications. EKGs annually was their recommendation from the Delphi consensus. And so this is really trying to reduce the barriers for our patients to get clozapine. The severe neutropenia is not the biggest side effect anymore. All of our antipsychotics have an incidence of causing neutropenia. And so really having one drug that was kind of carved out to watch for neutropenia really misled our providers and our patients and our pharmacists at what we should be looking at, and looking at the other adverse drug events that are more significant and affect everyday life for our patients. So what major event most significantly delayed clozapine's progression towards the FDA approval? It was that those 9 deaths due to secondary infections from severe neutropenia in Finland in 1975. Yeah, in 1983, we threw out the initial NDA, but that was just because it was based on old studies. We had to get new studies in here. Which of the following is recommended baseline screening before starting clozapine? CBC with diff, vitals, and EKG. You don't need to do the CRP or troponin at baseline. Hopefully their troponin should be negative, and CRP is just a marker of inflammation. So if they have inflammatory processes going on, like rheumatoid arthritis or osteoarthritis or just a viral infection, that could be elevated. So drawing that at baseline is not really going to tell us anything about myocarditis monitoring with clozapine. And then what receptor activity is most associated with the clozapine-induced hypersalivation? It's norclozapine's muscarinic 4 agonism and alpha-2 antagonism. And this is why the standard anticholinergics of just benztropine or diphenhydramine are not recommended for hypersalivation, as those are pan muscarinic blockers and not just aiming for the M4, and why localized treatment actually works better. So I'll end by saying I love this drug. This drug, I have seen changes over my 12 years career here. I have had patients come up to me and hug me. I've had parents come up and hug me saying this is a game changer. So for me, it is a game changer. I wear a tattoo of it on my left shoulder. I had to think about, I'm looking at the camera on my left shoulder. This is a picture of my tattoo. It sparks conversation when I'm out in the summer. It sparks conversation at dance competitions when I have a costume on, as I do dance with my son. But I get to talk about a drug that has changed patients' lives for the better. And that to me is reducing the stigma of this medication. And it really is underutilized. And I hope this was helpful for you and makes you feel a little more comfortable with utilizing clozapine. So I'll take if there's any questions.
Thank you, Dr. Nagy. If you're viewing online and have a question, please enter it into the Q&A section, and we'll make sure to ask that for you. We do have one in the audience.
Thank you, Dr. Nagy, for the talk. I'm Dr. Oleg. I'm one of the third-year psychiatry residents. I actually got my very first clozapine patient yesterday in clinic. So the timing of this talk was very fortuitous. My question is this. So patient's now 3 weeks on clozapine, doing very well clinically. Getting the weekly lab draws may be a barrier. So family's going to do their best, but they don't own a car, quite frankly. How long would you recommend to let him go without the lab draws, as long as clinically he's looking okay?
Personally, my opinion is whenever they get in. If risk versus benefit. The benefit of the medication, he's clinically doing well. There have been, in the last 3 weeks, no dyscrasias. History doesn't show anything. We're not seeing trends. If they can't get in for 10 days or 2 weeks, I've let it go. I've documented, hey, we're trying. There's a barrier. We will try again next week. But if the patient's doing well and I'm not seeing any fevers, so having them monitor their temperature at home, which is sometimes easy for them to do, and any actual side effects of oversedation or new drugs, I kind of let it go personally.
Thank you.
Hi, good afternoon. I'm Dr. Cleveland, fourth-year psychiatry resident. So since we know that cytokines like interleukin-6 can downregulate CYP1A2 activity by up to 90% during active infections, should we be more proactive in teaching patients and their PCPs to preemptively lower their clozapine dose at the first sign of a high fever or systemic infection rather than waiting for signs of toxicity?
I would worry about destabilizing the patient as well in an acute infectious process. So having that conjunction or monitoring them like, hey, you're ill, right? We may need to come down on it, but let's, have that conversation on a daily basis almost. I know it's more time consuming for the PCP, but I would hate to bring it down too quickly and destabilize the patient where they have to be hospitalized both acutely for medical and psychiatric at the same time. And so, if there is caregivers involved, I've had it where caregivers are monitoring that and communicating with our nurses and myself so that we're adjusting the dose as we go. And then as they get well, we adjust it back up. We would hate to just take it down and then hope that that's what happens, because if the patient does not have that happen, then we risk destabilizing them.
I'll take our last one. It's Sam.
Hey, Sam.
So I was a little curious about the new FDA guidance in the New England Journal of Medicine on the one pivotal trial rule. And if you could just share your thoughts on how that transition from 2 trials to 1.
I have such a hard time with the FDA's approvals, and I tell my residents here a lot. I'm like, oh, I don't really. I think we're gonna see more meds get approved almost, and then the post-marketing data show that they're not as effective or less effective than placebo. As there are drugs that have been approved recently, and I won't speak to which ones, but they separated at one dose. And I'm like, how do we know? I feel there might be more study error there. I like replication. I really feel I have a hard time accepting it. So kind of it's going to make me take a more critical eye to the newer meds that are approved and where to utilize them in patients who maybe have failed everything and we need to try something else versus, you know what, we have a lot more data on something else. Let's try that. So that's kind of where my opinion kind of falls right now, personally.
It's very helpful. And thank you so much for giving the talk again.
Yeah, thank you for inviting me. I really had a pleasure.